Lost your way, lost your cool, then you straight up lost your mind. Tried so hard to stay ahead, but you keep falling behind.
Good morning, we're gonna get started here. Good to see everyone, lots of old faces, and even better to see some new faces. So welcome everybody to our session, which is entitled Managing Hyperkalemia in Heart Failure Patients While Maintaining RAS Inhibition Therapy. My name is Marie Galvao. I'm going to chair the session today. And before I introduce our faculty, I'm just going to take care of a few housekeeping notations. First of all, I want to thank AstraZeneca Pharmaceuticals for providing an educational grant for this session. The program management services are provided by Vox Media. And of course, the symposium is sponsored by AAHFN. Please do take a moment right now to complete the brief questionnaire that's been distributed. The staff will be collecting this questionnaire as we begin the program. In addition, attendees, as you know, may earn CE credits by attending the meeting and completing the evaluation for the AAHFN annual meeting sessions. Please also see faculty disclosure information in the handouts, and additionally, complete the evaluation for this symposium also included in the handout. Representative slides are included in your handout, and they are also available on the AAHFN app. And presentations may also be viewed later on Medscape. Question cards are being distributed. Personnel will collect those cards throughout the program. Last but not least, please turn off all electric devices or put them on silent mode. So without further delay, let me introduce our faculty. To my left, Lisa Rathman is the lead nurse practitioner in the heart failure section at Penn Medical in Lancaster, Pennsylvania. Lisa will be speaking first, and her presentation is titled Hyperkalemia and Risk in Heart Failure, the Impact of RAS Inhibition Therapy, Discontinuation, and/or Dose Reduction. Following Lisa, Dr. Stephen Green will be speaking. Dr. Green's an associate professor of medicine at Duke University School of Medicine and the Duke Clinical Research Institute in North Carolina. Dr. Green will be speaking on treating hyperkalemia and outpatient RAS inhibition therapy in the heart failure population with potassium binders. Following their two presentations, I will do a brief case study. I'll pose some questions to our panel, and then we will open it up to Q&A to our audience. So let's get started, Lisa.
Okay, well, thank you, Marie, for that kind introduction, and thank you to our sponsors of this event for this. So I'm going to talk about hyperkalemia and risk of heart failure, the impact of discontinuation of RAASi therapy or dose reduction. So here are my disclosures. I don't have any specific disclosures related to this presentation. So these are objectives for this session. I'm going to cover the first objective to discuss the relationship between down titration or discontinuation of RAASi therapy and clinical outcomes. So imagine you're back in clinic. Okay, this is actually, as I was preparing for this talk, this is a true case. I was in clinic, typical Friday afternoon, because that's when all the lovely things come to you, Friday afternoon. But this is a case of a patient. I don't follow this patient, but was followed by somebody else in the practice, sent to me to address their potassium level, as you can see. So 72-year-old gentleman, history of heart failure, systolic, ischemic cardiomyopathy, type 2 diabetes, hypertension, chronic kidney disease. You can see his GDMT, not quite ideal. And you can see his potassium level of 5.7. So Friday afternoon at 4 o'clock, always get those kind of charts. And this is one that came to me. So let's talk a little bit about potassium homeostasis. So normal potassium homeostasis involves delicate balance between intake, excretion, and distribution between the intracellular and extracellular compartments. We know that 98% of potassium is found within the cells. and about 2% is found in the intracellular compartment or in the plasma. Small shifts in potassium, though, can have significant impacts in cell membrane stability and impacts on our patients. So normal potassium is important for cell function as well as heart rhythm. So how about normal kidney potassium homeostasis? So most excess potassium is removed by the kidneys. The kidneys remove about 90 to 95% of our excess potassium intake. About 5 to 10% is removed by the kidneys. Now in patients who have end-stage renal disease, who are on hemodialysis, that does upregulate by about 3 times in the intestines. But normally the kidneys play a very crucial role in excreting potassium from the body. And that balance is through filtration, reabsorption, secretion with aldosterone, regulating the potassium excretion via feedback mechanism through the sodium-potassium pump. Hypokalemia or hyperkalemia occurs in the advent of reduced renal excretion as well as potassium shifts as well as increased potassium intake. So what represents hyperkalemia? So normal potassium is between 3.5 and 5. In my institution, it actually goes to 5.2. Hypokalemia, less than 3.5. Hyperkalemia is defined mild hyperkalemia greater than 5, moderate greater than 5.5, and severe greater than 6. We know that hyperkalemia is a risk to our patients because of potentially fatal arrhythmias. So what are the pathophysiologic mechanisms involved in hyperkalemia? So we know that reduced sodium excretion from the distal nephron, when potassium is not excreted, that's a risk for hyperkalemia. We know our 2 biggest comorbid conditions that are risk factors for hyperkalemia are diabetes and worsening renal function. So as your GFR reduces, we see the risk of hyperkalemia increasing. And we also see that when patients have hyperglycemia and reduced insulin, we have less potassium in the cells and more in the plasma and risk for hyperkalemia. Antibiotics, things like amphotericin, trimethoprim, heparin, reducing aldosterone, can lead to hyperkalemia, nonsteroidal anti-inflammatories. We know our medications that we all use as GDMT, the backbone of our therapies, ACE, ARB, ARNI, MRA, do have, they inhibit the renin-angiotensin-aldosterone axis and can be associated with hyperkalemia. The one thing I would say is that in the paradigm trial, we did see a little less hyperkalemia in the ARNI group compared to the ACE group. Aldosterone deficiencies, like in Addison's disease or adrenal insufficiency, we can see hyperkalemia. So this is a study by Groby, and what they did was they looked at the epidemiological studies that have been done with hyperkalemia and summarized the risk factors for hyperkalemia. And what they found was many of the patients we see, folks older than the age of 80, higher baseline potassium, history of previous hyperkalemia, comorbid conditions, diabetes, chronic kidney disease, vascular disease, worsening heart failure status. So the worse the patient's heart failure status, the higher risk for hyperkalemia. So those patients with more advanced heart failure. LVEF of less than 40%, patient not on loop diuretics, and our patients who are on RAASi blockers. So how common is hyperkalemia? So in the paradigm trial, they saw an incidence of about 15% in the paradigm trial. Again, it was lower in the ARNI group than in the ACE group. But what about in the real world, in real world populations? So this is a study from Denmark looking at the incident rates of hyperkalemia. In a population cohort based of over 31,000 patients with incident heart failure diagnoses. And you can see the risk factors for hyperkalemia were chronic kidney disease, diabetes, MRA use. You can see the incidence of about 40% with the potassium over 5 over 2 years, close to 20% potassium greater than 5.5, and about 9.3% for potassium greater than 6. The greatest predictor in this cohort was the patient's degree of renal impairment. So what about the phenotype of your heart failure and your risk for hyperkalemia? So this is a study out of Sweden, looked at 5,000 patients, and what they found was an incidence over about 5 years. About 24% of patients had a potassium greater than 5, and about 10% potassium greater than 5.5. You can see across the board, though, with regards to phenotype of heart failure, the incidence was about the same. So what about potassium and mortality? So this is a study, this is a US study, looking at a EMR database registry of patients, geographically diverse group within an EMR set across the United States, looking at potassium variation and mortality. And what you can see with potassium is there's a U-shaped curve. So low potassium, higher mortality, higher potassium, higher mortality. You can see the control group, which was about 300,000 patients, did not have any medical issues. The biggest group was the 900,000 patients who had either hypertension, chronic kidney disease, diabetes, or all three. And you can see in the control group and also in the other groups, the lowest risk of hyperkalemia, or the lowest risk of mortality, excuse me, was when your potassium was between 4 and 5. And so that's where we want our patients' potassium to live, is really between that 4 and 5 range. You can see with the control group, if their potassium got a little bit above 6, that's when you start seeing mortality increase. But if you look at the risk for our patients with diabetes, then heart failure, then chronic kidney disease, and then all three, that risk goes up substantially when their potassiums go above 6. So really, it's increased mortality with both low and high potassium levels. So this is a paper from Dr. Green. If you've not read it, it's a great paper. It's only a couple pages, but talks about really the importance of what we do and getting patients on GDMT. So step 1, get patients on the 4 pillars of evidence-based medical therapy for HFrEF. So ARNI, evidence-based beta blocker, MRA, SGLT2 inhibitor. Get them at least on those low doses of foundational therapies. And then as the patients tolerate, increase those doses to maximally tolerated levels or target dosing, and do that quickly. And why? Because it matters for our patients' survival. So the most important part about this slide is down at the bottom, that cumulative risk reduction for patients. So relative risk reduction of 73%, and for patients, median survival extended by 7 to 11 years. That is huge for our patients, and I personally share that with all of my patients. So that when I talk to them about, hey, we're gonna put you on this agent, they're like, okay, I'll take it, absolutely, because it does extend their survival, improves their quality of life, keeps them out of the hospital, and keeps them well. But we know that hyperkalemia can be a risk for our patients. We do see it in clinical practice. So this is actually a survey from the ESC that was sent out to providers. It was sent out to physicians, and it wasn't just about hyperkalemia. It was about their prescribing practices for HFrEF. And it was all medications in HFrEF. I pulled out the potassium section. But it was sent out, 26-item survey, sent out to 91 countries. There were 432 responses. 90% of the respondents were cardiologists. 30% of the cardiologists were heart failure cardiologists. And they asked a question, what potassium would trigger a change in therapy? So about, I can't see from here, but 25% changed their therapy with a potassium of greater than 5. About 64% changed their therapy for a potassium greater than 5.5. And about 11% changed therapy with a potassium of greater than 6. And what was the change? What was the first strategy that they employed? About 54% either lowered or withdrew MRA therapy. About 18% added K-binder. About 10% added a resin K-binder, and about 9% lowered or withdrew RAASi therapy in patients. So what about discontinuing or changing therapies? So this was a study out of Sweden looking at patients who were in the Swedish SCREAM registry with new starts of MRAs. What they looked at was with hyperkalemic episodes, potassium greater than 5, what would they discontinue? So in about 43% of patients, they discontinued their MRA. 22% discontinued their RAASi inhibitor, and about 58% discontinued their MRA based on a potassium of greater than 5.5, and about 27% discontinued their RAASi inhibitor for potassium of greater than 5.5. The most important point about this was 75% of patients were never retried on an MRA after that happened. And what were the clinical outcomes? Again, this is more data from the Swedish SCREAM registry, looking at over 7,000 patients. Nearly 70% had heart failure. And what you can see here is the risk of death, MI, stroke, worsening heart failure was increased when you stopped therapies with patients. So there was about 11% change in mortality when you discontinued RAASi therapy for patients after MRA discontinuation. And you can see if you continued the MRA, there was a risk of increase in hyperkalemia subsequent. But I also want to comment, though, back on the other graph. If you look at that risk, if you see the curves, they split pretty early. Like in about 3 months, you start seeing increased risk for patients after you've discontinued their MRA therapy. So this is data from the United States, again, looking at a retrospective analysis, large EMR data, over 20,000 patients with heart failure with at least 2 potassium readings, and looked at their RAASi therapy. And you can see the patient's risk for mortality on the y-axis, on the x-axis that the patients maintained on their RAASi therapy. If you down-titrated or stopped their RAASi therapy, you saw fully a 2-fold increase in mortality for that patient. So some strategies to prevent hyperkalemia and heart failure. So discontinue concomitant medications that impair potassium excretion, so non-steroidal anti-inflammatories. Herbal preparations, I don't even know what some of these herbal preparations are. I don't know why you would take dried toad skin, but apparently that some people do. Horsetail, lily of the valley. So getting rid of herbal supplements that may be impacting potassium. Low potassium diet. Discontinuing salt substitutes. Our patients, when we tell them they're supposed to restrict their sodium intake, the first thing is their cousin found them this great thing at the supermarket called a salt substitute, which substitutes basically potassium for sodium, so they're dumping that all over their food. That may be just enough to get rid of their hyperkalemia, so stopping salt substitutes, stopping their potassium supplementation, finding out if the patient's taking potassium supplementation, and doing an adequate medical rec when you see that patient, medication reconciliation. Use of loop diuretics to facilitate potassium excretion, and careful surveillance of potassium and kidney function. And Dr. Green is going to talk a little bit about RAASis and SGLT2 inhibitors and their impact on hyperkalemia. So take-home message, treatment with RAASi improves outcomes in heart failure but increases risk for hyperkalemia. Hyperkalemia is common in the heart failure population. Hyperkalemia or fear of hyperkalemia is a major driver of underuse or underdosing of RAASi in heart failure, and dose reduction or discontinuation of RAASi is associated with worse outcomes in our patients. Thank you.
All right. First of all, thank you so much for the invitation to be here. I really love coming to this meeting, and again, such an engaging group of people, so thanks so much for inviting me. So I'll be discussing treating hyperkalemia and optimizing RAASi therapy in heart failure with potassium binders. So how do we actually manage hyperkalemia in real-world practice? And Lisa showed some great data from the ESC, but I think really it also applies to the United States. And generally, when you take a step back and think about what we do when we actually encounter hyperkalemia, usually it's either not very good for the patient in their risk of outcomes, or it doesn't even do a good job of managing the potassium at all. So really, we don't have a lot of success with our current strategies, but what do those strategies usually look like? Well, they include things like maybe increasing the dose of the loop diuretic to help excrete that potassium, but of course that ramps up your RAASi system and has a lot of negative outcomes for our heart failure patients. You might start a potassium binder like SPS or Kxalate, but of course that has a lot of side effects. It can be dangerous if you give it for long-term chronic use. What we usually do, though, is we end up sacrificing our GDMT. We stop the MRA, we stop the RAASi therapy, and then we leave our patient at that excess clinical risk without those therapies. So that's the status quo approach in the United States when we see hyperkalemia. But the reality is, in 2025, we have multiple tools in our toolkit to help manage hyperkalemia and heart failure. We're going to go through some of those tools today. Two of those tools are our guideline-directed medical therapies, which we already should be using to manage our patients' outcomes, reduce risk of death, heart failure, hospitalization, and the like. But what you may not realize is that two of these therapies, like SGLT2 inhibitors and ARNI, have benefits on hyperkalemia. So SGLT2 inhibitors, for example, they have consistently decreased the risk of hyperkalemia across a whole host of trials, whether you're talking about kidney trials, heart failure trials, diabetes trials. They decrease the risk of hyperkalemia. And sacubitril valsartan, among patients that are on an MRA, sacubitril valsartan decreases the risk of hyperkalemia compared to an ACE inhibitor. But then we also have a third tool to help manage hyperkalemia, and that's our novel potassium binders, patiromer and sodium zirconium cyclosilicate. These can be very helpful for treating active hyperkalemia. They decrease the risk of recurrent hyperkalemia if you give them chronically, and there's evidence to support them being useful in titration and maintenance of our GDMT so we don't have to discontinue. So we're going to go through the data for these three different tools. So first, with SGLT2 inhibitors, I already mentioned multiple clinical studies have showed that, oh yeah, by the way, on top of those benefits on hard clinical outcomes, they also decrease risk of hyperkalemia. On the left-hand slide, these are pooled data from the EMPEROR-reduced and EMPEROR-preserved trials. These are the trials with empagliflozin versus placebo in heart failure. You see here an 18% highly statistically significant decrease in the risk of hyperkalemia or need for potassium binders when the patient is randomized to an SGLT2 inhibitor as compared with a placebo. And then when you see the patient population among heart failure that needs the most help with hyperkalemia, the ones that are already treated with an MRA, we see a potentially even heightened benefit in prevention of hyperkalemia. In DAPA-HF, for example, dapagliflozin cut the risk of hyperkalemia in half for those HFrEF patients treated with an MRA. But it's not just about preventing hyperkalemia and making the blood tests look pretty. The reality is that these strategies, whether you're using SGLT2 and ARNI, initiating these drugs reduces MRA discontinuation. You see in the real world evidence, MRA needs all the help it can get with implementation. But we see consistent signals that both SGLT2 inhibitor and ARNI can certainly help out our friend the MRA in terms of keeping that therapy on board. Data, for example, on the left-hand side from Emperor Reduced showed that among patients that were on an MRA to begin with in the trial, if you got randomized to empagliflozin, you had a 22% lower likelihood of discontinuing that MRA during follow-up. Likewise, sacubitril/valsartan versus enalapril. Sacubitril/valsartan significantly decreased the risk of MRA discontinuation during follow-up in Paradigm HF. So to think about this, taking a step back, when we delay initiation of an SGLT2 inhibitor, or we delay that switch from an ACE inhibitor to an ARNI, we are needlessly exposing our patients to excess risk of hyperkalemia and also excess risk that we're going to end up sacrificing and discontinuing that MRA down the road. But now let's shift to talking about our novel potassium binders, because there's going to be a substantial residual risk for many patients, even with an SGLT2 inhibitor, even with an ARNI instead of an ACE inhibitor. So we need to have other tools, and that's where we'll discuss patiromer and sodium zirconium cyclosilicate, or SZC. So first with patiromer, this is a cation binding molecule that binds potassium in exchange for calcium, and it works in the distal colon. It's a powder, just like SCC is, and when you take it, it takes about 4 to 7 hours for the onset of action, but there's data to suggest that it can certainly be maintained for chronic use upwards of a year or more. One thing to tell your patients is we ideally like to avoid concomitant other medications taking around 3 hours within the dose of patiromer. And then one of the side effects that we think about is hypomagnesemia. That's kind of the word association. Again, it's a low risk overall, but it is about 5% chance of developing hypomag with patiromer. So what are the data that support the use of patiromer for our heart failure patient population? Well, it starts with the DIAMOND trial. Now, I'm going to walk you through the DIAMOND trial. Again, it's a little complicated study design, but I think it makes intuitive sense when you think about it. So this was a pretty large trial, 880 or so patients, all had heart failure with reduced ejection fraction. And it enrolled two types of patients. It enrolled patients that had active hyperkalemia on RAASi therapy, or patients that were normokalemic but we're on suboptimal RAASi because of hyperkalemia in the past. So again, either actively hyperkalemic on RAASi or normokalemic now, but not on optimal RAASi because we're worried about hyperkalemia that's happened in the past. Took this patient population, again, all with HFrEF, and first it started with what's called an open label run-in, where all 880 patients or so were initiated on patiromer up to 3 times a day, with the goal being to optimize RAASi, to really ramp up the RAASi, including the MRA, while maintaining normokalemia. During that open label run-in, 85% of the patients were able to get on good RAASi therapy and with a normal potassium value. So again, that right there is a finding that this patient population we normally weren't going to give RAASi to, we're too nervous about it. With patiromer, 85% were able to ramp up to really high levels of RAASi. But then came the second phase, which was the randomized trial part. Here, we took those patients on high-dose RAASi, normokalemia, randomized half of them to continue patiromer as needed versus withdraw patiromer. Kind of take the rug out from them after now that they were ramped up with their RAASi therapy and see what happens with their ability to tolerate and maintain normokalemia. So this is one of the key endpoints in the DIAMOND trial. So continuing patiromer decreased the risk of hyperkalemic events over 5.5 by 37%. So again, maintaining patients on patiromer, 37% risk reduction for hyperkalemic events. But again, it wasn't just about hyperkalemic events. It's also about maintaining that intense RAASi therapy, specifically MRA, and maintaining patiromer, 38% lower likelihood of discontinuing or decreasing the dose of MRA. So it allowed better persistence of MRA if we kept the patiromer going. In terms of safety, overall very well tolerated therapy. There was actually numerically fewer adverse events in patients getting patiromer than placebo. All right, now we'll shift gears to the other novel potassium binders. Here we're talking about SZC. And instead of binding calcium like patiromer here, this is an exchanger with sodium and hydrogen for potassium. Has a quicker onset of action versus patiromer. Here we have onset as early as 1 hour after the first dose. Like patiromer though, that we do have data suggesting that it can be very safe for chronic treatment up to a year or more. This is unlike patiromer working in the distal colon. This actually works throughout the entire GI tract, which again may be why it has an earlier onset of action. In terms of side effects to watch out for, so there can be a risk of edema with this therapy, and again we'll talk more about that a little later. So what is our foundational evidence for SZC in heart failure? Well, there was Diamond with patiromer. In SCC, we have what's called the RAASi trial. This was a smaller trial, about 202 patients were in the randomized fashion, but again, very conceptually similar design as Diamond. Again, it took patients HFrEF, and it took patients that were either, again, actively hyperkalemic on suboptimal RAASi, or normokalemic, but at a high risk of developing hyperkalemia, including hyperkalemia in the past. Took those patients, they were again started with this called open label run-in for up to 6 weeks or so, where the goal was to really ramp up the RAASi and MRA therapy and use the SCC as needed to maintain normokalemia. Then after that phase, patients were then randomized 1-to-1 to either continue SCC versus take away SCC and see what happens. So the primary endpoint in RAASi was a composite of maintaining normokalemia on high-dose spironolactone without the need for any rescue therapy. And when you look at this endpoint for those that continued SCC versus withdrew from SCC, more than 4-fold higher chance of maintaining this primary endpoint with continuation of SCC, and you see a substantial absolute gains of about 70% versus 35%. But again, relative terms, 4-fold increased benefit. But looking at the secondary endpoints in SCC versus placebo with RAASi, again, looking at normokalemia on even the randomization dose of spironolactone, so not even just the 25 milligram or higher, but what you actually fully got to, including 50 milligrams in some cases. Again, more than 4-fold higher likelihood of achieving that with SCC. Also, the chance of being on spironolactone at least 25 milligrams. Time to first hyperkalemic event that was substantially prevented or delayed when we continued SCC. And there was no difference, though, however, with the KCCQ quality of life between the two arms. But again, clear benefit on our hyperkalemia specific endpoints. When you look at the overall safety of the therapy, again, similar to patiromer, we see really no meaningful difference between total adverse events, whether you got SCC or placebo. However, there was a higher chance of heart failure AEs in terms of edema and cardiac failure AEs. You see 12 with SCC versus 4 with placebo. So maybe this goes along with some of the edema issues that we saw in some prior SCC studies in non-heart failure patient populations. But needless to say, when I sum it all up, when we manage hyperkalemia in our heart failure patients, we need to recognize that the risk of hyperkalemia, both the real risk but also the perceived risk or that fear of hyperkalemia, this is a frequent barrier to our initiation and up-titration of RAASi and MRA therapy for heart failure. But the good news is that with our contemporary tools, hyperkalemia can be safely prevented and managed without sacrificing GDMT. It's not an either or, either maintain normokalemia or get the patient on GDMT. Now with our tools, we can do both. And that includes SGLT2 inhibitors, ARNI instead of an ACE inhibitor, and the novel potassium binders. With the novel potassium binders specifically, we can talk about whether we should even do a proactive approach where you do upfront prophylactic use of these agents to prevent hyperkalemia versus a reactive approach which you know that you have it in your back pocket and you can use it reactively if hyperkalemia were to develop. We can talk about that. But either way, we should know that with the availability of novel potassium binders, it should give us confidence that we should be aggressive with RAASi and MRA, including re-challenging patients that have had reported prior intolerance. You need to be aggressive, especially knowing you have novel potassium binders in your back pocket if needed. Thanks very much for the invitation and great speaking with everyone.
All right, I am going to move on to a case study. These are my disclosures. All right, so this case is a 63-year-old male, reduced EF, ischemic etiology that was diagnosed back in September of last year. His EF is 20%, as you can see here, and he has some significant past medical history pertinent to this case, including type 2 diabetes, hypertension, history of hyperkalemia, and also CKD3. So when we met him in November, he was actually pretty well compensated, NYHA class 2. His exam was notable for a marginal blood pressure. So our plan was to optimize GDMT, and right from the start, we realized we had 3 significant barriers ahead of us, including low BP, this history of hyperkalemia, and also CKD. So when we met him, these were his medications. From a heart failure perspective, you could see he was on modest dose carvedilol and he was on dapagliflozin. Medical records indicated that the patient was previously prescribed both spironolactone and sacubitril valsartan. Each was discontinued for hyperkalemia. We really didn't know much beyond that. So, we can't emphasize enough, which you've heard from both Lisa and Steve, discontinuation of these therapies is real. This study that I'm showing you here, I'm not sure if you're familiar with it, but Evolution HF looked at 250,000 patients across the globe. It was an observational study that followed patients from initiation of therapy through a year. And if you can see here in red, an ARNI was stopped a quarter of the time. ACE or ARBs were stopped a third of the time, and MRAs were stopped almost half of the time, 42% of the time. So this issue of discontinuation of RAS inhibition in heart failure reduced EF is quite concerning. So you can see here, this gentleman's labs, when we met him, he had a borderline potassium of 5.0, CKD, as I mentioned, with a GFR of 42 and a BNP in the 900s. You could check the boxes with this guy. I know Lisa showed you a very comprehensive slide of all the risk factors for hyperkalemia, but he certainly had quite a number of them. So we decided to introduce 26 milligrams of sacubitril valsartan, BID, but without getting into a really long discussion. This guy has one of the most difficult insurance plans that we've certainly ever dealt with. We couldn't get it, and we ultimately ended up having to settle for losartan 25 milligrams. So we did start that. We reinforced the diet and confirmed no use of culprit meds. I also want to just emphasize, ask a patient if they're taking multivitamins, because many times when we do med recs, patients don't include that, and often multivitamins can have potassium in them. We did refer him to a nephrologist just to rule out other causes of hyperkalemia, and 1 week after we started the losartan, we checked his labs, and you can see here that his potassium, to no surprise, marginally went up to 5.2, which is consistent with mild hyperkalemia, and he had a mild bump in his renal parameters. So over the upcoming weeks, we really diligently up-titrated his beta blocker, continuously dealing with this low blood pressure. We continued his SGLT2 inhibitors, which actually, as you've heard, is, in addition to all the favorable effects of the SGLT2 inhibitors, also is effective in attenuation of the risk of hyperkalemia when co-administered with RAS inhibition. We monitored his labs closely. As you can see here, he still remained mildly hyperkalemic. So we then decided to add spironolactone 12.5 milligrams, and we concurrently added SZC 10 grams every other day. The choice of drug was really, again, insurance dictated. We advised the patient not to take the SCC within 2 hours of taking other oral medicines to avoid binding. We then repeated labs after 1 week. His potassium was acceptable at 4.6, so we then up-titrated the spironolactone to 25 milligrams. We concurrently increased the SCC to 10 grams daily, and we repeated labs 1 week later. His potassium was then 4.7. As a reminder, we always tell these patients that these drugs go hand in hand. You have RAS inhibitors, you've got potassium binders, and we tell them over and over again, you're not going to use one without the other. And we do see this happen. I'm sure you all have seen this happen. Patients come in, they're taking their ACE arbor ARNI, and oh yeah, they stop the potassium binder, or vice versa. So we remind them of that. We also reinforce the meaning of hyperkalemia to these patients, because certainly I find that some patients don't really appreciate the implications of having a high potassium. Now, AAHFN guidelines do make recommendations on the monitoring of potassium and renal parameters after MRA introduction. You're going to repeat your chemistry at 1 week, at 4 weeks, and then every 6 months. But they don't really elaborate more on these high-risk patients. So high-risk patients meaning patients where you're concurrently giving potassium binders and RAS inhibitors. I've put some information here referenced below, and I'll actually give you that reference later based on a consensus panel, which really nicely provides suggestions on how to do this monitoring in these high-risk patients. And as you can see here, the recommendations are to initiate your therapy. You're going to check your first labs within less than a week. You're going to then check them again in another week, so twice in 2 weeks. If your serum potassium's in range, you're going to repeat your labs in a month, and then every 3 months thereafter. So the recommendations are a little more stringent monitoring than in your average patient. Really importantly, you're going to remeasure labs with any potential electrolyte or volume changes, and this is really important. We lecture patients to be alert to signs and symptoms of congestion, but in these situations, we have to remind them that we want to know if they're going to get hypovolemic for any particular reason. So most commonly, something like a gastroenteritis, right? Somebody's vomiting, diarrhea, their potassium levels could go down, but then again, if they go into kidney failure, the potassium could go up. So really important to remind them of that. As mentioned earlier, with patiromer, you're going to want to measure serum magnesium, and then with SCC, you're going to also be conscientious to evaluate them for any signs of worsening heart failure or fluid retention and edema. So this gentleman's labs remain stable. You can see his potassium still in range. His blood pressure continues to really be a thorn in the side here, but he's not on bad therapy at this point. Carvedilol, 25 milligrams BID. DAPA 10 a day, spironolactone 25 milligrams a day. He's still on low-dose losartan 25 milligrams a day, and then of course the SZC 10 grams daily. Just for interest, we did repeat his echocardiogram 3 months after what we considered to be optimally tolerated GDMT. His EF went from 20 to 30%, but certainly was still in the range of needing an ICD. Patient education, I think, can't be overemphasized. Now, interestingly, there is some data out there that suggests reducing potassium-rich foods maybe just weekly impacts on serum potassium, but I have to say, I think you really have to think about your starting point. So I have a number of patients that come from the islands, Puerto Rico, the DR, the Virgin Islands. I find that my patients routinely have very high dietary intake of citrus fruits, especially plantains, mangoes. So I have found anecdotally that altering the diet really can help. So I do discuss that at length. Many of the points here we've already talked about, but one other thing, make sure the patients alert you if they're having GI side effects from these potassium binders. It can happen if they don't tell you, they may stop it or they may reduce it without ever alerting you to that. And then again, I can't emphasize enough, report any conditions that can affect volume. they may or may not be cognizant of that. So, I work in the Bronx. It's the least healthy county in the state of New York. We have a very high rate of diabetes, poor glycemic control. We routinely can see hyperkalemia, 400s, 500s, with hyperglycemia. With hyperglycemia, you can see hyperkalemia. So that's another common clinical scenario where I'm dealing with high potassiums in the setting of poor diabetic management. You've heard a lot of already, but I think we really have to be aware of these common barriers to the utilization of potassium binders for the purpose of RAAS inhibitor titration and ongoing use in heart failure patients over the long term. And importantly, you've heard a lot about the after effects of either reducing these therapies or discontinuing these therapies. Many of those I have listed here. I will make a couple of comments on, patient non-adherence. There are a handful of patients that I just cannot go this route on. They're just too non-adherent to trust that they're going to maintain both these therapies. But for the most part, you can do this. Time, effort, reinforcement, it works. I will also point to the fact that I think there's a clinician underappreciation of the importance of ongoing RAAS inhibitor use in this patient population. Also, I just will point out, we hear a lot about this clinical inertia. I think that's really something to think about. It takes work to get patients on board using both these therapies and to monitor them. And I think sometimes, clinicians get caught up in not having enough time, too many patients, just not having that, ability and or motivation to really put their patients through what it takes to get them on these dual therapies. But when you look at the morbidity and mortality outcomes, obviously we really owe this to the patients and we really need to do this. I made reference to a consensus paper that you're going to see on the right here, which was recently published. On the bottom, I'm just emphasizing there's a really nice table in there, a nice algorithm. This is how I initiate these therapies. This is when I monitor. This is what I do if the potassium's in range or not in range. On the left is actually, a paper published 7 years ago from our European colleagues. It's an older paper, but I think it's actually very applicable. So 2 really good references that you may want to take a look at. So I'm going to end with the case here, and I'm going to just pose a couple questions to our panel, and then we'll move on to audience Q&A. All right, so, okay, Lisa, maybe I'm going to start with you. This patient, potassium was running 5.1. We initiated a low-dose ARB. We then checked labs a week later. My question to you is, would you have concurrently started the SCC when you initiated the ARB? And in general, what's your threshold in regards to a potassium level for concurrently administering the potassium binder versus introducing something, checking the labs, and then taking that next step to add a potassium binder?
I think this doesn't work. So I think your approach with your patient, because of their previous history of hyperkalemia, would have been the route I took. Had they not had previous history, I may have just checked their labs a lot more frequently, like weekly, and just put them on it to see what happened to their potassium, rather than initiating it at that time.
And so we initiated 10 grams every other day. Is that the dose you would have gone with, or do you normally just start with daily?
Daily.
Daily,
yeah.
Okay. All right, Steve, you were in reference to some discussion that you had about, retroactively giving these therapies, proactively. So in this case, again, we didn't feel that we needed to introduce a potassium binder prior to starting the losartan. What is your potassium level threshold, so to speak, for instead initiating a potassium binder, driving down the potassium, and then adding an ACE, ARB, or ARNI? So more of that 2-step approach versus the way we did it concurrently.
Yeah, so I think, let's talk about MRA specifically. So if someone's not on an MRA already, and your potassium is 5 or greater, the guidelines say you shouldn't start an MRA. Can't do it. So in that situation, I'm certainly going to upfront use a potassium binder to try to drive that potassium down in an acceptable range, because then it allows me to initiate an MRA. Now, for RAASi, it's a little bit of a judgment call if your potassium is like in the mild hyperkalemia range. For me, if the patients can persist consistently there, so let's say they're not on a ACE or an ARB or an ARNI or whatnot, and you've been sitting chronically in that 5 to 5.5 range, I am, generally speaking, going to treat it like an MRA and try to drive that potassium down and get it in an acceptable range and then start the ARNI. Or I might do it concomitantly, though, where I don't do it stepwise. I do it both at the same time, prescribe potassium binder and prescribe the RAASi at the same time, because I'm that confident that the potassium binder, assuming the patient can access it, is going to be very effective in keeping the potassium okay.
So your threshold a little bit different for MRAs versus ACE, ARB, or ARNI?
Yeah, it's just like it's a letter of the law for MRA is like you cannot initiate MRAs if your potassium is above 5. You just can't do it. Whereas for RAAS inhibitors, maybe there's a little bit of wiggle room and everything. It's not as much of a hyperkalemia risk, so maybe you could initiate and then check it and make sure it's not in the moderate or severe range. But generally speaking, if someone's been in the mild hyperkalemia range, for me, even with initiation of a RAASi, I'm generally speaking going to want to pair that with a potassium binder.
Maybe I'd pose the next question to both of you, really. So in your practices, or maybe even within your institutions, not just the heart failure practice, just what would you say is the most common reason for maybe failing to be able to maintain patients on RAAS inhibition with a potassium binder, and about how often, what percentage of time do you think that's an issue?
I mean, I think that we underutilize potassium binders in our institution. I think the fear of hyperkalemia, the fear the patients won't continue their therapy is high, and that gives people pause. I think that's what I see in our institution, is overcoming that clinical inertia.
Yeah.
So I'll give you my anecdotal response, and then I'll give you what I think Diamond and RAASi showed with this. So essentially, it's like, I think your question is, how many people are like fail a potassium binder where they have refractory hyperkalemia despite a potassium binder. In my own clinical practice, and I prescribe a decent number of potassium binders, I've never had a patient fail it, where they we can't get their hyperkalemia under control, and they're taking it, like Patiromer you can take up to 3 times a day. I've never had that happen to me. And usually my patients are taking it a couple times a week or something like that. They don't even require it daily. They require some, but not a ton of it. So I've never had anecdotally a patient fail where we can't achieve normal kalemia and have good RAASi therapy, anecdotally. But now in the trials, there were some people, in that run-in period for, Diamond, for example, 85% of the patients that weren't on good RAASi therapy and they were high risk for hyperkalemia or actively hyperkalemic. So 85% of them, yes, were able to ramp up to good doses of RAASi and achieve normal kalemia, but about 15% didn't. So even with, again, aggressive use of a potassium binder, we still couldn't achieve both, where they were simultaneously on RAASi and normal kalemia. Now, of that 15%, not all of them failed the run-in because of that. There were some other issues. Maybe someone had side effects and dropped out. But generally speaking, even in the clinical trials, it's low that people with aggressive use of potassium binders as needed can't achieve the dual goal of being normokalemic on good RAASi MRA.
Okay, so it sounds like maybe clinical inertia is probably the main reason for a lack of introduction of these dual therapies. Is that fair?
Yeah, I think in my opinion, I mean, we just have to have that desperation with heart failure. It's a cancer diagnosis, and I mean, we get all nervous, appropriately so, if you have a cancer patient, you're not giving chemotherapy. We look for any which way. How can we enable them to get their chemotherapy? What can we treat them with concurrently to make their chemotherapy more well tolerated? And we need to have that same sense of desperation when we're talking about GDMT for heart failure. It's the same prognosis as a cancer. We need to have that same desperation of any which way get these drugs, these 4 pillars for HFrEF and SGLT2 and MRA for HFpEF. We need to do everything we can to get these patients on these drugs and have that desperation, and that includes reaching for potassium binders. But what do you think, Lisa?
I would agree with that wholeheartedly.
Yeah, that's actually a great analogy. Certainly, yeah, if it's a patient with a cancer, you're doing everything to sustain them on their therapies.
Yeah.
But so, I think that sense of urgency just has to be there.
The one thing I find though, to get patients on the 4 pillars, you have to sometimes be a salesman to convince patients because they're already on so many other medications for their comorbid conditions. They're like, you want to add how many new medicines? And, but I find, if you can get them on the right therapies, perhaps they need a little less diuretic, maybe you can cut back on some other things for patients. This, I think, again, clinical inertia, I would see as the biggest issue.
Do we have any audience questions? We have 2 microphones set up, and I believe maybe we have some set. Thank you. All right. Okay, so first question. Maybe I'll pose this to Lisa. Are you starting potassium binders inpatient? And can you just speak to any comments about monitoring and the difficulties of monitoring?
So we've used them in patients who have hyperkalemia on the inpatient side. My experience has primarily been in the outpatient clinic to get people on GDMT.
Okay.
But we've used them inpatient, have not needed to continue it outpatient in the several patients that I've seen.
How about you, Steve?
Yeah, we used it inpatient and outpatient. Again, my clinical trial data showed these drugs work for controlling potassium. You saw in RAASi, 4-fold higher chance of maintaining normal kalemia. So they're very effective at potassium. We use them inpatient and outpatient as needed.
Yeah. I will say, in my institution, I don't see a lot being used inpatient. Often patients get discontinued with that note that says, RAAS inhibitors held for hyperkalemia, reconsider in the outpatient setting. The problem is, we will do that, but I think in the average practice that doesn't happen. We've all probably seen those notes in the chart that say, you want to check the boxes for the 4 pillars, right? So you say, patients on beta blocker, patients on SGLT2 inhibitor, and then you'll see that line that says, failed RAAS inhibition for hyperkalemia, and that's it. And I think what we all have to realize is that, no, that's not it. So there should be another qualification there that either says patient is not a good candidate for potassium binders because X, or give a reason. But all too often we just see that escape of, I know they should be on a RAAS inhibitor, but here's my reason why I'm not putting it on. I think we have a question here.
Yes. Hi, Stacy Gross, Cedars-Sinai Medical Center, Los Angeles. Thank you, all 3 of you. Phenomenal talk and extremely pertinent to practice. Regarding the 2 potassium binders we currently have on the market, any experience in terms of hypervolemia given the sodium content of one is far greater than the other?
Yeah, I can talk about this. So SCC did have that edema signal in prior studies, and again, there were a numerically higher rate of heart failure events in the SCC group versus placebo and RAASi, although no difference in cardiovascular mortality. And the thing with this, from a trialist perspective, it was 200 patients, small numbers. The trial was not powered for that. The trial was powered to say, does it control potassium, and it certainly met that primary endpoint. But there is that, like you mentioned, that biological theoretical risk, since it's an exchanger with sodium, maybe it leads to sodium retention. In my own clinical practice, I haven't noticed it as a big issue, to be quite frank. It's hard to know. Heart failure patients, have hospitalizations, they have swelling issues. Hard to know if that's SZC related or if it just was going to happen naturally. I haven't noticed an overt, obvious issue in my own clinical practice, but there does seem to be a potential signal, again, in the small studies that have been available.
I agree. That's been my clinical experience.
Yeah, it certainly seems very manageable, to be quite honest, and hasn't, I use whichever one of the 2 is best for the insurance that the patient has, and it's usually the insurance has a strong preference for one over the other, and I just go with that, and I haven't had an issue.
So one other comment, we actually sometimes send patients home with one packet or the other, or a couple of packets to have on hand if I'm concerned that there's going to be a risk of hyperkalemia starting GDMT or up titration. So usually the patients that I'm concerned are high risk for hyperkalemia, I may prescribe a couple packets or have it at home to take on an as-needed basis.
Yeah, that's actually a really great suggestion. I don't know if everybody heard, she was just saying that high-risk patients will send home with a packet of a potassium binder just in case. It's a great, I just had a patient literally a couple of days ago, it's in the evening, potassium was 6.2, and adamantly refused to go to the ER. A prescription was put in for a potassium binder. The next morning, insurance hadn't improved it. Then we had to order K-Exolate. It turns into like a mess. And if we had had a packet or two at home, we could have saved everybody that hardship. So thanks for that notation, because I think that's really important. Okay, I think we are just about out of time. So thank you everyone for attending. Please make sure you get all that paperwork in. Thank you.